You are my lightning too. So again, the places it kills you are TBI and burns. So before we talk about where it's beneficial, what is the cost? The relative cost, I'm going to ask Evan, what do you think the relative cost is of albumin versus crystal lead? Fivefold. Chris, what do you think relative cost is?
Of what?
Albumin versus crystal lead.
Like tenfold.
So you can like do a selfie there. What do you think the relative cost is?
I'd say 50-fold.
10, 5, 10, 50. What do you think, Ray?
20.
It's 60. So it's 60 times more expensive.
Prices
So until we had the albumin protocol, albumin is one of the 5 most expensive drugs we had at this hospital. And actually, back when I was at WashU, the exact same thing. Both places ended up with an albumin protocol. Because if you think about how crazy expensive some chemotherapy drugs are, right? Like $100,000 to give somebody chemotherapy drugs. For albumin to end up in the top 5 of a hospital formulary is crazy, right? And so it means that A, it is relatively expensive, and B, it means that we are using a crap ton of it. Now, it's okay to use a crap ton of it as long as it's being evidence-based. So again, think about when you prescribe an antibiotic. If you have an antibiotic to tell you work in the ED, if you have 2 antibiotics that have the same efficacy and one costs 60 times higher, are you going to give the one that costs 60 times higher?
No.
No, you will not. You always, when you're looking at giving a drug, and albumin is a drug, fluids are drugs. When you give somebody a drug, the first thing you're looking for is efficacy and side effect profile. After that, you look at price, and then after that, you look at local culture. So if there's equivalent efficacy for something which costs 60 times more, you would never ever give it. Hence why we have our first patient of the week on linezolid rather than vancomycin, because there's equivalent efficacy. So why would we use the thing that costs 60 times more? So for us to use it, and we have historically used a humongous amount, we have to say why. So there's been a whole bunch of studies about prospective randomized trials about when it is actually indicated. And there are clearly times that it is life-saving. Prospective randomized trial, you do better. Anybody know? There's a bunch of them. If you've read our protocol, you probably know most of them already. Anybody know? Anybody?
Hypotension during dialysis.
Intradialytic hypotension, which was the indication for using it here. Totally appropriate. Okay? Others. Hepatorenal syndrome. Absolutely. And again, as the liver unit, we use an awful lot of it because we have a lot of the reasons. Okay? Anybody else?
Large volume, SPP and large volume.
You actually just said 2 different things, and they're both right. So SPP and large volume para. By the way, this is not always, there's 2 different types of albumin, right? There's 5% and there's 25%, and not every one of these is 5% or 25%. So you should feel free to look at the guidelines to make the determination when to see when one works versus the other works. Because it's not just albumin, it's knowing which one to give. So, by the way, either you guys have already looked at the protocol or you guys are much better than my typical teams who can't come up with any of them. And you came up with 2 of them in the same sentence. What else?
I'll put it up here.
Anybody?
You can use it in burns after.
You can use it in burns, but that's can as opposed to prospective randomized trials. You can use it in a lot of places. Prospective randomized trials showing it improves outcomes. We need to plug that in, or it's going to drive me insane.
We can plug it in over there.
Also for like shocking stuff.
For what?
Shocking during ECMO.
Okay.
I don't know if that's an actual true indication.
No, it's not a true
Yeah, but we do use it.
Okay. Yeah, I'm not saying it's wrong, and then we're going to get to when should we and when should we not. So we're now talking about the things that unequivocally are beneficial. Unequivocally, as much as you can say it, beneficial. SPP, hepatorenal, large volume para, intradialytic hypotension. What else? Anybody?
Can't think of any other times when I've ever given.
There's 2 others that we talk about. One is a lot and one is a little. The one that's a little is single organ failure, ARDS, and the push me pull me. So trying to get rid of fluid off the lungs when it's just ARDS and nothing else. So this is actually done out of Grady, out of Emory, and the PI was Greg Martin, who you guys may or may not know, who was the head of the MICU at Grady and wrote the paper in the Epidemiology in the New England Journal of Medicine of sepsis. And Tina, our night NP, used to be his research nurse. So he had an NIH grant for this. They couldn't actually recruit anybody because the entry criteria were so incredibly strict. But I actually got that put into our albumin protocol because the work was done at Emory. And even though it's very, very difficult, if you truly have somebody who is volume overloaded, wet lungs, ARDS, and nothing else, the albumin push me, pull me, give it intravascular, give Lasix at the same time, which people talked about beforehand, but actually is only indicated for literature-wise for that, and it's literature-wise based upon a pilot study, but it wasn't people. It was published in Curricular Medicine. The biggest one, by far, which nobody's mentioned, anybody knows what? What?
I know we do it, but you also do it for like fast intraoperative blood loss.
Right. So there's I think that's going to change because actually the healthcare system is looking at albumin usage and specifically is looking at intraoperative usage as being totally off protocol. The protocol doesn't talk about anesthesia at all. But as an FYI, the healthcare system and some of the vice presidents up top are specifically looking at anesthesia usage because while you would have no reason of knowing what practice is at Emory versus practice at other places, so you assume that wherever you train, what you do is what people do around the country. It's not. And there's a crap ton more albumin used intraoperatively here than there are at peer institutions. And the easiest way I have of knowing that, other than the fact that I trained in another institution, but again, I'm old, it's been a while, is our anesthesia fellows. So our anesthesia fellows who trained elsewhere say, when they rotate through 5E and we go through this, say, oh my God, oh yeah, we use like 10 times more albumin here intraoperatively than they do at other places for peer cases. We just use a lot. So that's actually not evidence-based. The other place that is evidence-based, in a controversial way, and I'm going to go through the literature, is sepsis, which nobody mentioned.
That's two pressors. You have to be on like a bunch of pressors, right?
do not.
Okay.
The two pressures were for steroids.
Okay.
So this is, and it's difficult to put this into bullet points, so I'll take a vast literature and try to bring it to a few things. The biggest study of albumin is something called the SAFE trial. And to get into the New England Journal of Medicine, you need a cool acronym. Saline versus albumin for fluid evaluation, SAFE. The SAFE trial looked at albumin, giving everybody albumin, and it did not show any benefit towards giving albumin. There was a post hoc of it killed people in TBI, a post hoc of killed people in burns, and a post hoc of it was beneficial in sepsis. So based upon that, and then based upon some smaller studies, a meta-analysis was done. This is, by the way, what comes with the 2012 surviving sepsis recommendations. A meta-analysis was done, which if you included children, if you included pediatric patients, showed that albumin was beneficial for mortality in previously called severe sepsis, now called sepsis and septic shock. That's a meta-analysis. There's going to be more data since then. That's a meta-analysis. Dominantly, the one biggest group in the meta-analysis was a post hoc version of a prospective randomized trial that was positive, although it wasn't determined specifically for sepsis alone. Based upon that, if you look at surviving sepsis, it gets a relatively weak recommendation to use sepsis, to use albumin in sepsis, and it doesn't really explain when. And if you looked at nerdy listservs, it basically says to do it when you give so much volume that you're hurting the oxygenation. That's state-of-the-art 2012-2013. Okay. Since then, there's something called the Albios trial. I don't remember what that stands for, but that was also published in the New England Journal of Medicine, specifically looking at albumin in severe sepsis and septic shock. I actually think that's what it stands for, albumin in severe sepsis, septic shock. And if you only read the abstract of that, you will come up with the conclusion that albumin is not beneficial. That's the abstract for the New England Journal paper. Albumin did not change outcomes. Then if you looked at, they had two predetermined subgroups, severe sepsis, what we now call sepsis, and septic shock. The patients with severe sepsis did not have a benefit by giving albumin, even in the predetermined subgroup analysis. The patients in the pre-hoc septic shock had a better mortality. So now we have two different prospective randomized trials, SAFE and Albios, that when you do a subgroup analysis of septic shock, have a better outcome. Based upon that, there's two meta-analyses that have come out, one in 2013, one in 2014, or 2014 and 2015, I can't remember which, looking at almost the exact same data and coming to totally disparate conclusions because they change 200 patients or something. One of them comes up with the conclusion that, and this is the Cochrane database, which, well done, comes up with the conclusion that if you look at albumin and sepsis, there's no harm, but there's no benefit, and therefore we shouldn't be using it. If you look at the British Medical Journal, also a very good journal, and you look at it, they say there's no benefit in severe sepsis, but there is a benefit in septic shock. Again, they put all the things together in a meta-analysis, and it doesn't cross midline. So you could take all that, and depending upon whether you see the glass is half empty and half full, and I don't actually know exactly what surviving sepsis is going to say in the next version because we keep arguing about it, but you can basically say there is a meta-analysis based upon 2 prospective randomized trials in the New England Journal of Medicine supporting using albumin and septic shock, and there's another one that doesn't. So despite the fact that everybody thinks I hate septic shock, especially the surgery people, the truth is you can point to literature that says albumin is appropriate to use in septic shock. We don't exactly know when, and most people would say if you give enough crystallite to hurt your pulmonary mechanics. We haven't heard of pulmonary mechanics in here, but you can make an argument that this would be a perfect place, separate from the intradialytic hypotension, to say, you know what, I'm concerned the patient's septic, I'm concerned we're giving so much volume, I would like to give albumin, and I would say you're being totally evidence-based. If you say I looked at the same literature and I come up with the conclusion that it's not beneficial because the meta-analysis says it's not, then it's not. So that is actually the biggest one. So even though we're liver land here, and we do have SPP, and we do have large volume para, and we do have hepatorenal here, and we do have intradialytic hypotension, by far the biggest reason to give it a 5E, if you want to believe it's evidence-based, based upon a meta-analysis that came out last year, is sepsis. And I'm not going to come at you and say you're wrong, because you could say, look, LBS trial, SAFE trial, meta-analysis, and I'd be like, okay, you know your literature, it's all good. That leaves everything else. So everything else is where we get into the problem. So it works in large volume para. Does it work in small volume para? We took off a liter, so I'm giving albumin. A liver transplant, when you take off a bunch of ascites during the case, is a large volume para. So if your drains are putting out 4 or 5 liters a day, that's a large volume para. So giving albumin after a liver transplant when the drains are putting out a lot is a lot. How about if the drains are putting out 500 cc's? This is where we get into the problem in 5A and other places as well, is the transitive property, right? And so it works in liver stuff within a lot of the things I just told you. So if it works in those liver stuff, then it must work in all liver. So anybody who has a liver disease should get albumin no matter what. If it works in liver, there's HPB, therefore it must work in pancreas. So we'll start talking about giving it a pancreatitis. If it works in pancreatitis, it must work in intra-abdominal surgery because they're both in the abdomen. And so we have lots and lots of people, residents, and also some of one or two of our attendants, at least one of our attendants, and some of our APP staff who just like it because they believe that it will suck things intravascularly and it will work because there's data in liver. Does it suck things intravascularly? It does. The problem with that is, again, somebody with way too much time in their hands actually radiolabeled albumin. And what they did is they radiolabeled albumin and gave it and see what happens. So initially it stays way more intravascular than crystallite does. We know that. That's a duh, right? That's the theory. It's going to stay in, going to suck things in. Unfortunately, 36 hours later, more of it is extravascular than the crystallite. And so the benefit you get standing in front of your patients, you're like, yay, I sucked all this stuff in, totally goes away and actually gets worse 36 hours later. And when you're giving it for somebody who's sick here, right? You're not giving it for somebody who's going to be better 36 hours later. So all the benefit you think you're getting by sucking things in doesn't actually work. And so giving it evidence-based fashion, again, SVP, HRS, large volume para, intradialytic hypotension. If you want to say for single system ARDS that push me, pull me, that's totally legit. I got that added to the protocol. And if you want to say sepsis, as long as you can quote the literature, I'm perfectly cool with you giving the sepsis, which frankly is half the unit. That's the evidence-based. We don't see TBI burns here, so it's not relevant here. It's relevant to Grady. And then there's everybody else. I just gave it because I did, or because they had intra-abdominal surgery, and that's when all of a sudden you have no data to back you up. And when you have no data to back you up, it goes back to the conversation of where we started with. If something costs 60 times more, you would never give something that costs 60 times more without clear evidence of its advanced efficacy. So there's lots and lots and lots of times to use it, and truly this is the single best ICU across the entire Emory archipelago to use it because we're liver land and everybody's on dialysis. We do a third of the CRT across all of Emory in this one ICU. So this is the perfect place to use albumin, and we have so much sepsis. And when you're giving it outside of that, you're just spending 60 times more, and you're causing problems to the healthcare system, and it means we're not getting a new something else that we actually need because we're wasting money, the equivalent if we put everybody on daptomycin and linazolid instead of putting them on vancomycin. Okay, that's a little more than 10 minutes. Pretty close there. Questions?